Hello, today me and my friends going to present about chapter 13, the psychological disorder. Okay, so let's go to my first slide. Generalized anxiety disorder is like the worry of the things that going to happen really bad in the future. It's like you feel that it's going to have like a tsunami happen tomorrow or like a flooding happen tomorrow, including like you feeling that it's maybe about the money that it's going to be like gone away, the economy going to be really bad like that. Next is the panic disorder and agoraphobia. It is the experience that make you feel like uh it's the experience that come up to your brain and make you feel really really scared and afraid of it, and you cannot control yourself. It's like when you walking in the temple alone with like a one candle, then you saw like a woman, like a ghost, that you the old woman that make you feel like she was not a human anymore. She was a ghost. So and you feel like screaming out, but like cannot control yourself and screaming out or like jump up. So that is the things that will be happen by the panic disorder and agoraphobia. Okay, so next specific phobia is the fear of something pose little or no actual danger. It's like you are scaring, afraid of the cockroach, and you know that like cockroach cannot do any bad effect to you. They cannot bite you or something like that. Cannot kick you, cannot punch you, but you still scared of it. Mhm. Next is the social anxiety disorder. It's like you are feeling that you are not like supposed in to be in this social, in this society. You feel like you are different, and it's make you feel suffer. I'll give you the very good example. It's like when you're in the school, in the classroom, and the test score is coming out. After the test, right, the test score will come out, and you can't, your score is very low from your friend, and you feel like, oh, I'm not supposed to be here because like my score is so bad, but my friend still got a very good score, and they lead like the same all the time with me, and they're like with the same number of the same timing with me, and they still got more than me. I think that there was something bad happened. Like I cannot go on this anymore. I cannot take this anymore. That is what is the social anxiety disorder. Next is the post-traumatic stress disorder. It's the mental health condition triggered by a terrifying event like the flashback, like that. So it's like when you sleep and you feel like, and you dream with a night, and you saw like a nightmare, you found somebody trying to kill you or something like that all the time. Okay, thank you.
This slide about obsessive compulsive disorder, obsessive compulsive disorder or OCD. These thought and compulsive behavior don't just come and go. In strange and unusual. Thoughts are taking thoughts are taken to mean something much more important and real, maybe even something dangerous and frightening. OCD might become preoccupied with the possibility that the behavior was not carried out to completion and feel compelled to repeat the behavior again and again, maybe several times before they are satisfied. The last one about treatment for anxiety and related disorder. Maybe successful treatment for anxiety and related disorder have been developed over the years. Medication have been found to be beneficial for disorder other than specific phobia, but relapse rates are high once medication are stopped, and some classes of medication can be habit-forming. Neurodevelopment in the treatment of anxiety disorder are focusing on novel intervention such as the use from certain medication to enhance learning during CBT and transdiagnostic treatment targeting core underlying vulnerability. Hi Professor, today I talk about mood disorder. This is a group member. This slide about mood episode. Major depressive episode or MDE refer to symptoms that co-occur for at least 2 weeks and cause significant distress or impairment in functioning such as interfering with work, school, or relationship. Manic or hypomanic episode. The core criteria for a manic or hypomanic episode is a distinct period of abnormal and persistently euphoric, expansive, or irritable mood and persistently increased goal-directed activity or energy. Mood disorder. Unipolar mood disorder. Two major types of unipolar disorder described by DSM-5 are major depressive disorder or MDD and dyspersin Depressive disorder or PDD. MDD is defined by one or more MDEs, but no history of manic or hypomanic episode. Criteria for PDD are feeling depressed most of the day for more days than not for at least 2 years. Like MDD, this symptom needs to cause significant distress or impairment and cannot be due to the effect of a substance or a general medical condition. To meet criteria for PDD, a patient cannot be without symptoms for more than 2 months at a time. PDD has overlap symptoms with MDD. If someone meets criteria for an MDE during a PDD episode, the person will receive diagnosis of PDD and MDD. Depressive disorder. Depressive is a mood disorder that's caused a persistent feeling of sadness and loss of interest, also called major depressive disorder or critical depression. It affects how you feel, think, and behave to can lead to a variety of emotional and physical problems. Depression is not limited to industrialized or Western culture. It is found in all countries that have been examined, although the symptom presentation as well as prevalence rate vary across culture?
So is my part dissociative disorder. In psychopathologies, dissociations happen when thoughts, feelings, and experience of our consciousness and memory that they can cooperate well with each other. Is it real? Multiple personalities disorder or disorder in which people present with more than one personality. For example, at times they might act and identify as an adult, while at other time they might identify and behave like a child.
Hi, for this slide about bipolar disorder. Bipolar disorder is an emotional disorder which patient with this disease will have a different mood during the present mood, alternating with period of better mood than usual. And for the symptoms in each phase can last for weeks or even months. Those diagnosed with bipolar disorder prior to allow who experience a more pernicious course of illness related to those with adult onset, including more episode recurrence, higher rate of suicidality, and so what are some of the factors implicated in the development and cause of mood disorder? Mood disorder are complex disorder result from multiple factors. Causal explanations can be attempted at various levels, includes biological and psychological levels. There are several key factors that contribute to onset and cause of mood disorder that are depressive disorder and bipolar disorder. For depressive disorder, the essential feature of major depressive disorder is the patterns in the periods of 2 weeks during which there is either depressed mood most of the day nearly every day, or loss of interest for pressure in daily or activities. And in terms of bipolar disorder that includes the above depressive symptoms. It also includes symptoms of mania. Bipolar disorder is characterized by mood swings that fluctuate between depressive lows and manic highs. What are some of the levels of support treatment for mood disorder? For depressive disorder, the earliest antidepressant medications were monoamine oxidase inhibitor, or we call MAOIs. MAOIs can have serious side effects. The patient with taking MAOIs may develop dangerously high blood pressure if they take certain drugs. And another one is tricycle, are most effective of treating somatic symptoms of depressions. And the last one is selective serotonin reuptake inhibitor, or SSRIs. Are the most of recently introduced antidepressant medications. And for bipolar disorder, patients with bipolar disorder are typically treated with pharmacotherapy. For bipolar disorder, lithium is a first-line treatment choice. Lithium acts on several neurotransmitter systems in the brain's complex mechanism. including the reductions of excitatory like dopamine and glutamate. For conclusion, when people experience an MDE and bipolar disorder or a manic episode, they are developed differently. During an MDE, people often feeling hopeless about the future and may even experience suicidal thoughts.
Good morning. My name is Sudhafi Tawachainan, and my student number is 621000694. So here we go. Actually, this is not the exact topic I'm going to say. So let's move on. So the first page is talking about defining dissociation. So dissociation is a disruption, disruption and discontinuity in the normal integration of consciousness, memory, body representation. So and also state dissociation is billed as a transient symptom which lasts for a few minutes or hours. Trait dissociation is viewed as an integral aspect of personality. Dissociative symptoms occur in patients, but also in the general population like you and me. So the dissociation disorder include the first one, dissociative amnesia, second, dissociative fugue, and the third one, depersonalization, and the fourth one is dissociative identity disorder. What is depersonalization? So depersonalization refers to a feeling or detachment or estrangement from oneself. Moreover, derealization is defined as an alternation in the perception of one's surroundings, so that a sense or reality of the external world is lost. Measuring dissociation or DES. DES is come from the dissociative experience. It is the most widely used self-report measure of dissociation. So it is a type of psychological test in which a person completes a survey or questionnaire with the help of investigator. Also, DES is suitable only as screening tool when somebody scores a high level of dissociation of this scale. So this doesn't necessarily mean that he or she is suffering from dissociative disorder, but it gives an indication to investigate the symptom more extensively. So talking about dissociation and trauma. It is the most widely held perspective on dissociative symptom that it reflects a defensive response to highly aversive events and most trauma experienced during the childhood years. One prominent interpretation of origins of dissociative disorder is that they are the direct result of exposure to traumatic experience. So we will refer to this interpretation as the PTM. So the PTM can best be understood as as mental strategies to cope with or avoid the impact of highly aversive experience. So it can become automized and habitual, even emerging in response. So the idea that dissociation can serve a defensive function can be traced. Second, causality and evidence. So it is a subject of intense debate. So there are three limitation of the PTM below. So the first one, cross-sectional design. The majority of studies report links between self-report trauma and dissociation are based on cross-sectional design. This means that the data are collected at one point in time. So when analyzing this type of data, one can only state whether scoring high on a particular questionnaire. So the second, a self-report measure. So whether somebody has experienced a trauma is often established using a questionnaire that the person completes himself or herself. This is called self-report measure. So herein lies the problem. The individual suffering from dissociative symptoms typically have high fantasy proneness. So the last one, cognitive failure. So high dissociative individuals report more cognitive failure than low dissociative individuals. So cognitive failure are everyday slips and lapses, such as failing to notice signposts on the road, forgetting appointments, or bumping into people. So most important, however, is that the PTM doesn't tell us trauma produces dissociative symptoms. So the last one, sleep dissociative and sleep. Some researchers, Watson, has proposed that dissociative symptoms such as absorption, derealization, and depersonalization originate from sleep. And it was often described as somnambulism, which referred to a state of sleepwalking. So sleep problem in patient with dissociative disorder. A patient with mood disorder, anxiety disorder, a condition with relatively high level of dissociative symptom as a rule exhibits sleep abnormalities. Studying the relationship between dissociation and sleep. In general population, both dissociative symptoms and sleep problems are highly prevalent. Inducing, and go back, and it also shows that dissociative symptoms measured by the DES are linked to self-report of vivid dreams, nightmare, recurrent dreams, and other unusual sleep phenomena. So there seems to be a strong relationship between dissociative symptoms and unusual sleep experience that is evident in a range of phenomena. Inducing and reducing sleep problems. Sleep problems can be induced in healthy participants by keeping them awake or a long time duration of time. So this is called sleep deprivation. And implication and conclusion. The sleep dissociation models offer a fresh and exciting perspective on dissociative symptoms. Both models can be integrated in a single conceptual scheme in which traumatic childhood experience may lead to disturbed sleep pattern, which may be the final common path to dissociative symptom. Thank you.
Okay, so the next chapter is schizophrenia and spectrum disorder. The phenomenology of schizophrenia and related psychotic disorder. It is also likely that you have met people with schizophrenia without ever knowing it, as they may suffer in silence or stay isolated to protect themselves from the horror they see, hear, or believe are operating in the outside world. As this example begins to illustrate it, psychotic disorder involve many different types of symptoms, including delusion, hallucinations, disorganized speech and behavior, abnormal motor behavior, and negative symptoms such as anhedonia, amotivation, and blunted affect, reduced speech. Delusions are false beliefs that are often fixed, hard to change even when the person is presented with conflicting information, and are often culturally influenced in their content. They can be terrifying for the person who may remain convinced that they are true even when loved ones and friends present them with clear information that they cannot be true. The most common delusions are persecutory and involve the belief that individuals or groups are trying to hurt, harm, or plot against the person in some way. These can be people that the persons know. Other types of delusion, including grandiose delusion, where the person believes that they have some special power or ability. Referential delusions, where the person believes that events or objects in the environment have special meaning for them. When you see a person on the street talking to themselves or shouting at other people, they are experiencing hallucinations. These are the perceptual experiences that occur even when there is no stimulus in the outside world generating the experiences. They can be auditory, visual, olfactory, gustatory, and somatic. The most common hallucination in psychosis are auditory and can involve one or more voices talking about the person, commenting on the person's behavior, or giving them orders. The contents of the hallucinations is frequently negative and can be the voice of someone the person knows or a completely stranger. Talking to someone with schizophrenia is sometimes difficult, as their speech may be difficult to follow, either because the answer do not clearly flow from your question, or because one sentence does not logically follow from another. This is referred to as disorganized speech, and it can be present even when the person is writing. Disorganized behavior can include odd dress, odd makeup, or unusual rituals. Flat affects and reduced speech reflect a lack of showing emotions through facial expression, gesture, and speech intonation, as well as reduced amount of speech and increased pulse frequency and duration. Schizophrenia is the primary disorder that comes to mind when we discuss psychotic. So there are a number of other disorders that are share one or more features with schizophrenia. In the remainder of this module, we will use the term psychosis and schizophrenia somewhat interchangeably, given that most of research has focused on schizophrenia. The cognitive neuroscience of schizophrenia. Problems in cognitive functions are also a critical aspect of psychotic disorder and of schizophrenia in particular. This emphasis on cognition in schizophrenia is in part due to growing body of research suggesting that cognitive problems in schizophrenia are a major source of disability and loss of functional capacity. The cognitive deficits that are represented in schizophrenia are widely spread and can include problems with episodic memory, working memory, and other tasks that require one to control or regulate one's behavior. Individuals with schizophrenia also have difficulty when what is referred to as processing speed and are frequently slower than healthy individuals on almost all tasks. People with schizophrenia also show reduced over brain volume and reduction in brain volume as people getting older or maybe larger in those with schizophrenia than in healthy people. Taking antipsychotic medication or taking drugs such as marijuana, alcohol, and tobacco may cause some of these structural changes. However, these structural changes are not completely explained by medications or substances to use alone. A risk factor for developing schizophrenia. It is clear that there's important genetic contributions to the likelihood that someone will develop schizophrenia with consistent evidence from family, twin, and adoption studies. However, there is no schizophrenia gene, and it is likely that genetic risk for schizophrenia reflects the summation of many different genes that each contribute something to the likelihood of developing psychosis. Further, schizophrenia is a very heterogeneous disorder, which means that two different people with schizophrenia may each have very different symptoms. There are also a number of environmental factors that are associated with increased risk of developing schizophrenia. For example, problems during pregnancy such as increased stress, infection, malnutrition, and diabetes have been associated with increased risk of schizophrenia. In addition, complications that occur at the time of birth and which cause hypoxia are also associated with an increased risk for developing schizophrenia. Children born to the older fathers are also a somewhat increased risk of developing schizophrenia. Further, using cannabis increases risk for developing psychosis, especially if you have the other risk factor. Unfortunately, none of these risk factors is specific enough to particularly useful in a clinical setting, and most people with this risk factor do not develop schizophrenia. However, together they are beginning to give us a clue that the neurodevelopmental factors that may lead someone to be an increased risk for developing this disease. And the last one is the treatment for schizophrenia. There are two primary types of antipsychotic medication referred to as typical and atypical. The fact that typical antipsychotic help some symptoms of schizophrenia was discovered serendipitously more than 60 years ago. These are the drugs that all share a common feature of being a strong block of the D2 type dopamine receptor. Also, this drug can help reduce hallucination, delusion, and disorganized speech. They do little to improve cognitive deficit or negative symptoms and can be associated with distressing motor side effects. The newer generation of antipsychotics is referred to as atypical antipsychotics. These drugs have more mixed mechanism of action in terms of the receptor types that they influence. Though most of them also influence D2 receptor, these newer antipsychotics are not necessarily more helpful for schizophrenia, but have fewer motor side effects. However, many of the atypical antipsychotics are associated with side effects referred to as the metabolic syndrome, which includes weight gain and increased risk for cardiovascular illness and type 2 diabetes and mortality. Unfortunately, there are no pharmacological treatments that work consistently to improve cognition in schizophrenia. So many new types of drugs are currently under exploration. However, there is a type of psychological intervention referred to as a cognitive remediation, which has shown some evidence of helping cognition and functions in schizophrenia. Thank you for your attention.